So welcome, Dr. Montori. Please, the word is now with you. Thanks.
Thank you very much, Helen, and everyone else participating in today's webinar. This first slide has my email address as well as my Twitter handle. If you want to be in touch with me, these are two ways in which you can connect with me, and I'm usually pretty good at responding to either email or Twitter. And I will be delighted to hear from you. It's very important in this conversations to disclose any financial relationships, whether they constitute a conflict of interest or not. The CARE unit, the Knowledge and Evaluation Research Unit, is the context in which I've been conducting research about shared decision-making and other forms of patient-centered care since 2004, which is when I started this journey. And since the first day, we decided that we would not receive any funding from any for-profit corporation. As a result, I don't have any financial relationships to disclose. All my income is from my salary as a physician. I take care of patients with diabetes at the Mayo Clinic. This is a picture of Maria Luisa. And Maria Luisa has been a patient that has joined me in these presentations now for a few years. And I love to tell people about Maria Luisa. As you contemplate this picture, something becomes clear. That is, on the right-hand side of the picture, you see a lot of tablets of medicines that she has been prescribed. She has a lot of health care. But when you look at the left side of the picture and you look at her, and you look at her eyes, and you look at her expression, you get the feeling that Maria Luisa is not particularly healthy. So a lot of health care, but not necessarily producing a healthy result. How does it happen that healthcare respond to Maria Luisa? Well, we have guidelines that recommend treatments and tests for people like Maria Luisa. We have targets that we must achieve in terms of disease control that indicate to others whether we are offering Maria Luisa good care. We have new drugs and opportunities to improve the situation of people like her. And that is the problem. All this is for people like Maria Luisa. But our job as clinicians is not to offer care for people like Maria Luisa. Our job is to respond to Maria Luisa and to go beyond the biology to do that so that we can respond to Maria Luisa, taking into account her context, the totality of her personal situation, as well as her personal values, preferences, and goals for her life. If we just respond on the basis of the biology, we may provide, like in the case of Maria Luisa, a lot of healthcare, but fail to respond to her situation or to achieve the goals that she values. When people go back and look at the definition of or the description of evidence-based care, it is often described as bringing together the research evidence, the best available research evidence, with the patient's context, the patient's values and preferences. And usually it's framed as a clinician incorporating patient values and preference and context alongside research evidence informing plans of care. But in a patient-centered approach, a better way of characterizing this is that when patients and clinicians are together, considering the problematic situation of the patient, that they should take into account a number of information sources, including the best available research evidence, in deciding together what to do in a manner that will make sense to this patient at this time. It is not evidence-based care to figure out what the research indicates is necessary and then do it for every patient for whom the treatment or the test are indicated. Because once again, that will mean that we are treating people like this one and not this person. Now, there are a number of cultural efforts over the years to try to change this dynamic to make it more patient-centered. This phrase, "nothing about me without me," indicates that need to involve patients in the decision-making process. From an ethics perspective, there's been the case of autonomy, respecting patients' autonomy in making decisions. From a health services research and implementation science perspective, there's this notion of knowledge translation, in which we've been worried that we have all this evidence, but somehow it doesn't get translated into the care of patients, and that is a problem. From an economics perspective, healthcare economics perspective, there's been the interest in improving the value of healthcare. And improving the value of healthcare may include a more patient-centered approach. From a performance perspective, there are initiatives that pay clinicians for better performance. And they've been, in recent years, efforts to pay for involving patients in the decision-making process. But all of those are bad reasons, in my opinion, to pursue shared decision-making. The fundamental clinical reason to be interested in shared decision-making is the importance of forming plans of care that not only attend to the patient or respond to the patient's biology, what's wrong with their body, so to speak, but also take into account the patient's biography, where they're coming from, where they're going, what are they trying to achieve in their life, and how is this medical problem part of the problematic human situation that they're facing, and how do we as clinicians respond well to that circumstance. So the main reason to be worried and concerned and interested and get good at shared decision-making is because it's a fundamental skill in order to care well for patients, particularly patients that come to us with chronic conditions. So shared decision-making, and here's the first definition, if I may, shared decision-making is a method, and it's a method to care. If you want a more sophisticated definition, here's a different one. We think of shared decision making as a conversation, not as a speech, not as a monologue, but a conversation in which patients and clinicians work out, figure out, discover, uncover what is it that they need to do. What is the plan of care? They need to formulate a plan of care. And that plan of care, if it's done well together, should make intellectual sense. It seems to respond well to the problem that the patient has, is evidence-based. It needs to make practical sense. It can be implemented in the lives of patients. And it needs to make emotional sense. It needs to feel like the right thing to do. So shared decision-making is a conversation with a goal. The goal is to formulate a plan of care. And it shouldn't be any plan of care, but it should be a plan of care that makes sense as a response to the patient's problematic situation, that it makes sense intellectually, practically, and emotionally. It feels right, it's feasible in practice, and people can understand it as an adequate response to the patient's situation. How might we get to that plan of care? Well, it's an iterative process. This process starts by discovering or clarifying with the patient what is the aspect of the patient's situation that demands action, followed by discovering together what are the actions that this situation requires, that this situation demands. And this is a process that's iterative, that you go through cycles until you get it right. Let me give you perhaps a bit of a ridiculous example, but one that I think works well. Imagine a patient, a woman with a very large tumor in the pelvic area. This tumor is a malignant tumor, and without treatment will surely kill her soon. So what is the situation that demands action? We need to save this woman's life by treating her tumor. Okay? So what are the actions that possibly respond to that situation? Well, the oncologist might say that they can use chemotherapy and radiation therapy on the tumor, but the chances that that will work are very, very low, and the chances that the treatment itself will end up accelerating the death of the patient will be quite substantial. Well, that doesn't sound like a really good way of responding to the patient situation. The surgeon comes in and says, I can cut this woman in half right above the tumor. We throw away the bottom half, the pelvis and the legs with the tumor, and we leave the woman without the tumor, but she will only have to live her life from the belly button up, without pelvis, without legs. As the woman considers that possibility, that one doesn't seem also to be a good response to her situation. So then the arrow comes back to the situation, and perhaps we got it wrong. Perhaps this is a tumor that is going to end the woman's life. So what is the situation that demands action? Perhaps it is not to save the woman's life, given the options that are available. Perhaps the situation is, given that the tumor is going to kill this woman, are there ways of helping her die that will be more consistent with her wishes, more consistent with the way she would like to write the last page of the last chapter of the book of her life? And now we recognize that the actions as originally offered, chemotherapy, radiation, or a hemicorporectomy, that massive surgery, are completely inadequate actions in response to the situation that is now defined as one of helping her die well. And so that's the iterative process where we clarify the situation, find ways of responding to it, and oftentimes by looking at the ways available to respond to a situation, we further clarify the situation, and we keep moving in this way until we know together what is the right plan that makes intellectual, emotional, and practical sense. So it's important to think what inputs matter. And I think for shared decision making, the main thing to convince patients is that we are sincere in seeking their input. In cultures in which the doctor has too much psychological size, too much authority, or in which maybe some of our colleagues are a little bit arrogant in their way they conduct themselves, patients have learned that being quiet and accepting doctors' recommendations is the expected behavior. Asking too many questions, let alone having opinion about what to do, is clearly not acceptable, and they've learned that. So one of the things that we have to do to advance shared decision making is to be sincere in our request for patient input and convince patients that their input is absolutely essential. Without understanding the patient's problematic situation, the solutions that we are going to produce may very well be for patients like this, but they won't be for this patient. And as clinicians, we should learn that that is a failure. And we need to assess the quality of the work that we just did with each patient, asking ourselves, and more importantly, figuring out with our patients, is this solution a solution that makes intellectual sense? Listen, that hemicorporectomy, that surgery, would have made intellectual sense, but clearly for this patient, it did not make emotional sense. And living with just the upper half of her body did not make practical sense to her. So we need to make sure that the solutions, no matter how clever they may appear to the clinician, they need to make intellectual, emotional, practical sense to each patient. So after convincing patients that or in order to convince patients that their input matters, it's helpful to recognize and to let them know that this is a situation, the situation in which we're involving them, in which there is no technically correct answer. You see, if there is a technically correct answer and only one, it is a waste of patient's energy and time to ask the patient to tell us what they would like. You know, in the situations where there's only one technically correct answer, the approach is to say, look, this is the answer that is available to us right now. This is what we need to do. And then the process there is a process of informed consent. The patient acknowledges that that's the only way forward, and they agree to participate. This will be, for instance, the example where a patient shows up to the emergency room, has been shot, has a gunshot wound to the chest, and the technically correct answer is to take the patient to the operating room to repair the damage caused by the bullet. Asking the patients for their own perspective to see what makes emotional, intellectual, practical sense will be a potentially a poor use of precious minutes when we know that the only technically correct answer is to take the patient to the operating room. So we need to convince patients that in other situations that where we're involving them, there is no technically correct answer. We're not asking them for their views as a trick question. We're not trying to trick them. And if we are good at convincing patients that there's no technically correct answer, then we will also not get the usual response from patients where we try to involve them and they tell us, but doctor, I didn't go to medical school. How would I know what to do? That only reflects the idea that there is a technically correct answer and a sufficiently trained clinician should know what it is. So we need to convince patients that there is more than one potentially correct answer, and to figure out which answer is the right one depends on very much on patients' values, preferences, prior experiences, and other things about which the patient has unique expertise. And without consulting this expert, the patient, we run the risk of giving the wrong advice. And one of the best ways of completely sabotaging that process, of making it not work, is starting the conversation by giving a recommendation. So we have seen clinicians tell patients, look, I think you need to have surgery. Now, let's discuss the alternatives. If you notice that in order for the patient to now prefer an alternative, they'll have to reject the recommendation of the clinician in front of them. And when the stakes are high, when things matter tremendously, patients find rejecting the recommendation of a clinician whose life or well-being depends on very difficult. It's almost, it's a higher stakes version of when you go to a restaurant and the food comes out and you find that the food is undercooked and you want to send the food back to the kitchen. But you want to be very careful because you don't want the chef to be upset with you and maybe spit on your food before they send the food back out to you. In medicine, the stakes are much higher than having your food spit at by the chef. Many people have found shared decision-making to basically be giving material to the patient. If we just give education material to the patient or patient decision aids, then the patient will come prepared to the consultation with more information, and so the task will be easier. There is no question that our patients are in general undereducated about healthcare, and there is no question that it would be best if the health literacy, well, the literacy as a whole, but the health literacy in particular of our patients was better. But this is also overwhelming. And for patients, again, with chronic conditions, with more than one thing to learn and so forth, tired and with fatigue and symptoms and pain, having to learn all this material becomes very hard. Yet, a lot of the shared decision-making activity has been like this: distribute patient decision aids to patients and wait to see what happens when they use them. Clinical trials have demonstrated that this approach improves knowledge about the options, reduces the conflict people feel about what's the right thing to do, does not change or change the duration of visits by little time, and has a variable effect on what choices patients make, the cost of healthcare, or their outcomes. Many experts in shared decision-making like to say that when you distribute patient decision aids, patients tend to choose the treatments that are least invasive and least costly. But that often is the finding, because in settings in which those treatments, the most invasive and the most expensive, are overused. They're used more than they should. So when you introduce a question, a pause, or a patient involvement, the only direction those choices can go is down. But in situations where perhaps an expensive or invasive option is underused, the introduction of patient decision aids has the opposite effect, and that is the effect of increasing the use of the expensive and invasive options. So the effect that it has on the kind of treatment that people would choose and on the cost of that treatment depends really on the baseline level of use of those treatments. An alternative approach is to bring a shared decision-making intervention into the consultation. Remember the definition of shared decision-making as a conversation. So these are tools that are designed to support the conversation between the patients and clinicians so that they can form plans of care that make intellectual, emotional, and practical sense. The first tool that we ever developed for this purpose was the Statin Choice Decision Aid, which is available in multiple languages. The website is there on the top of the slide. And this starts by using a calculator of cardiovascular risk that provides a 10-year estimation. It uses risk communication approaches that are state-of-the-art. On the left-hand side, you can see a group of 100 people like the one we're seeing. It demonstrates how in the next 10 years, 79 of those 100 people like this patient will not have a heart attack, and 21 will. One of the, here let me pause for a second and make the case that there are multiple uncertainties around the evidence. First, is the evidence of high enough quality for us to find the estimates reliable? Second, is the precision of those estimates sufficient to support decision making? In this case, for instance, we have this estimation of 21% risk. Is it 21 as in 20 or 22, or is it 21, but it could also be 10 or 30? So that's another level of uncertainty. Let's call that statistical uncertainty. I would put forward that compared to the validity of the studies that support this estimate, which I think if it's too low, it should not be translated into a shared decision-making tool, and the statistical uncertainty, there is a much bigger uncertainty, which is expressed to the patient in the following way. Mirhelen, if this is you, I do not know if you're one of the green ones or one of the orange ones. I do not know if you're one of the people that will not have a heart attack in the next 10 years or one of the ones that will. That, to me, is a much larger uncertainty than the uncertainty as to whether we have 21 orange people, or if we have 15, or if we have 30. It's knowing whether you will be the one that will have the heart attack or you will be the one that would avoid the heart attack. This is compounded on the panel on the right, because if you want to show the effect of treatment, then you say, well, if we treat those 100 people like you, for instance, with a statin, a cholesterol-lowering medicine to be taken every day for the next 10 years, what would we expect? Well, we expect the 79 people who are not destined to have a heart attack to take medicine every day, see their cholesterol come down, but still no benefit because they were not destined to have a heart attack. Then we have, of the 21 people that were destined to have a heart attack, we have 16 that still get their heart attack despite taking the medicine regularly. So they also don't benefit. So that means we have 95 out of 100 people that will take medicine for 10 years every day and will have no benefit. And 5 people in blue will be safe. They were destined to have a heart attack, but they will be safe because they took the medicine regularly. Once again, I do not know if you are one of the green ones, one of the blue ones, or one of the orange ones. And that is the biggest uncertainty about this. And that is what we need to come to grips and understand, that when we prescribe medicines like statins, we sometimes get the comfort of seeing everyone's cholesterol come down. And so we believe that every single person that we are treating with statin is benefiting from it. But the answer is only, like in this case, if you look at a person at a risk of 20%, you're really only helping 5 out of 100 people. Which 5? I don't know. And the patient doesn't know either. And that is a way of communicating uncertainty to the patient about treatments, like in this case, statins. Also notice that we're using multiple ways of conveying risk. We're using numbers and letters, numbers and words on the sides. We're using this, what is called this pictograph of 100 people like you. Notice that if you step back, you will see almost like bar graphs. You can compare the difference in areas. If you are colorblind, you can also perceive not only the difference in color, difference in hues, but also we've introduced little happy faces and sad faces, so you can perceive that difference as well. And so instead of choosing one way or another of conveying risk, we're trying to use multiple ways of conveying risk to try to meet the risk communication needs of different people. When tested in clinical trials, we found that patients were 22 times more likely to have a sense of their risk and the benefits of statins when they used the statin decision aid tool than when they had an unaided conversation with their clinician. We also noticed that there were 70% fewer prescriptions in the group that was at the lowest level of risk. And there was an improvement in adherence to therapy, a 3-month, that was 3-fold increase in those who had used the tool, but that was self-reported, and so it's not as trustworthy. This is a different kind of decision aid. In this case, this is designed to choose from among the different options available to treat diabetes. And so this one starts by asking the patient, which aspect of your next diabetes medicine would you want to discuss next? And patients choose from the titles of these cards. For instance, they might be interested in weight change. With this card, they will discover that perhaps the metformin they're currently taking is weight neutral, that some drugs like insulin or sulfonylureas increase the risk of weight gain, and some drugs like liraglutide or the SGLT2 inhibitors reduce the risk of weight gain, in fact, produce weight loss. Let's say that the patient is interested in one of the 2 weight loss medicines. Then we go back to the cards and ask them, well, which aspect of those 2 medicines are you interested in discussing next? Maybe they want to know how they're used. And they find that this liraglutide medicine is an injectable medicine that you use on a daily or weekly basis. On the other hand, the SGLT2 inhibitors is a pill a day. They're interested in the pill a day. So then you ask them, well, what else do you want to know about that particular medication? And they might, cost might come up. And in the United States, these are expensive medicines costing between $8 and $10 a day, which compared to metformin, which is 10 cents per day, they're extremely expensive. Having realized that, the patient might then go back on their own, with their own eyes, to look for the next beneficial weight treatment. Find the gliptins here are also weight neutral, like the metformin. They're 1 pill a day, but they're also expensive at $7 a day. And you may see their eyes then go back and say, well, maybe I can't afford weight loss or weight neutrality. Perhaps I can tolerate a little bit of weight gain, take a pill a day for another 10 cents a day. And so for patients who are very sensitive to cost, that might be the right answer. While perhaps for another patient who might not have been too concerned about the pill cost, they may have chose those SGLT2 inhibitors the first time around. So this is a different kind of shared decision-making tool. And here the point of using the cards for the clinician is not as much to arrive at the right answer, but it is to listen to the reasons people give to pick the different cards and to pick the different agents in each one of those cards, and actively participate in the process of selecting their diabetes medication. Again, not necessarily to pick up the right answer, but to understand and listen carefully to the reasons people have to choose what they choose, because perhaps there are mistakes in those reasons, but perhaps they give you a little bit more insight, not only into the patient's biology, but also into the patient's biography. So these are things that help us with figuring out what is the what is the aspect of the situation that requires action. This is the latest tool that we've developed and tested, which in this case looks like the statin tool, and it helps us know that the reason we need to do something about it is the patient is at risk of stroke. This is for patients with atrial fibrillation, where we show them here a 12% risk of stroke. And then what might we do to respond to that? Well, we might use anticoagulation, and we show on the panel on the right the 65% risk reduction with anticoagulation on the risk of stroke. So what kind of anticoagulation can we use? Well, we can use a direct anticoagulant or warfarin. This is still part of the same conversation, shared decision-making tool. And then we can figure out which aspect of those anticoagulants would you like to discuss next, very much like the diabetes cards. Patients might, for instance, want to discuss how you take the medicine. They may want to look at the cost of the different alternatives. They may want to explore the potential risk of bleeding, not only on average terms, but also in relation to their lifestyle and figuring out what to do. The summary of all this experience has been that a lot of the myths that we started with back in 2004 are no longer true. We were told that shared decision-making was for young people, and we clearly have seen even people at the age of 95 participating well in the shared decision-making process. We were told that this was very good for the hospital and for specialty care, but we've done almost all of our work in primary care and some of our work even in the emergency department, where time is limited. And we've been able to design tools to support those conversations, even for fast-paced environments. We were told that there was no time for shared decision-making, and we've confirmed again that the use of tools now, not just the ones that you give patients, but also these ones that you use in the conversation, they barely add some time to the duration of the consultation. And we were told that clinicians will never be interested in the training necessary to do this well. And we've been able to demonstrate that with these very easy to use tools, clinicians can do a very good job without much training. Interestingly, clinicians in our studies have not been barriers to the use of shared decision-making or the use of these tools, with somewhere in the vicinity of 3/4 to almost 90% of clinicians wanting to use these tools and wanting to have these tools available to use them again with similar patients. We were concerned that supporting shared decision-making might be for the privileged, might be for those patients who are already empowered, they're well educated, and they come to see clinicians in settings where clinicians have enough time and training and tools to do this. But in our studies, when we have involved populations, people that were not as educated or were normally getting poor outcomes because of disparities in care, we found that what shared decision-making does is it works as a leveling intervention, in that patients who are already well educated and so forth may have already done their own investigation, their own research. They've been on the web looking for information. Perhaps those patients need less help. Patients that are more in a vulnerable situation may not have had the opportunity or the tools or the know-how to find that information themselves. So the shared decision-making tool allows them to perform similar to patients who have been able to help themselves. And just like with the prior research on patient decision aids, this encounter or conversation tools also have a variable effect on clinical outcomes, adherence to therapy, and costs. Interestingly enough, a consistent finding in our work has been that when you introduce tools for the conversation, you can turn conversations that are fairly technical, where in the case where we work, where the clinician is spending a lot of time looking at the monitor, at the medical record, and the patient is looking out the window bored and disconnected, the use of these tools often brings the patient and the clinician together. And now they are in a better line of conversation and communication that makes it more likely that the clinician will get to fully understand the patient's situation and they can work together to respond to it more effectively. This is the publication, our latest publication from that decision aid I just showed you, the anticoagulation choice shared decision making. This also happens to be the largest randomized trial of shared decision making in which the encounters, the clinical visits were video recorded in our field. And what we have noticed is that the main effect, the main result of this study, which was conducted in 5 healthcare systems with almost 1,000 patients, is that the quality of shared decision-making reported by patients, the decisions that they made about anticoagulation were no different between the intervention and the control arm, the intervention arm being the one that received the shared decision-making tool. The biggest difference that we found were in the clinicians were more satisfied after the shared decision-making encounters than after the usual care encounters. That was the biggest difference between the 2 arms of this trial. In this results table from that paper, you can see that the patient engagement score was a little bit better in the intervention arm than in the control arm. That effect was statistically significant, but the size of the effect is not very big. You can see the fidelity in which, in other words, the quality of the use of the tool by the clinicians, which is almost perfect. You can see that the tool was used in almost all of the encounters that clinicians were invited to use the tool. Most of the sections of the tool were used. One area of concern is that only in 13%, this is the next to the last line of this table, only 13% of the discussions were led by a patient priority. What that means is when instead of asking the patients what aspect of these different interventions would you like to discuss first, the clinician chose which intervention to discuss. So only in 13% the patient was able to determine what the order of discussion would be. Notice in the last line the difference in the encounter duration. On average, the encounter duration on the intervention, on the 419 encounters in the intervention arm was 32 minutes. The average duration in the standard care arm, 411 encounters, was 31 minutes, a difference that was not statistically significant. So where are we now? In this editorial we published in JAMA, we noticed that it is very difficult to know whether simply the introduction of shared decision-making tools can change the quality of care and the outcomes of care. It looks like the best that these tools can do is improve the conversation, in other words, improve shared decision-making, and that improves patient-centered care, but the downstream effect of patient-centered care remains unclear. We notice in this editorial that few studies had actually looked directly at the effect of these tools on shared decision-making. Our studies since 2005 have introduced cameras into the consultation so we can see the effect that these tools had on the interaction between patients and clinicians, and can say for a fact whether and to what extent the use of these tools changes that interaction towards a better conversation. And the fact that introducing shared decision-making has low cost and almost no risk, of course, doesn't eliminate the need for research in this area, because of course there are opportunity costs. There are other things that we may want to do with our time and with the patient's time, energy, and attention. I'm going to finish by pointing out that the context in which we work is important. We're trying to do all this work on shared decision-making at a time where patients are treated in healthcare systems in which patients are nothing but a blur. We see them too quickly. We don't know them very well. We sometimes see them as if they are represented by their test results. We know very little about their biography, and as a result, it's very hard to know well what is the nature of the problematic human situation. We meet in agendas that were very busy. There's a lot of things that we need to accomplish in the clinical consultation, and the agenda, the items, the to-do list for that meeting is often given by the healthcare system, by the clinician, rarely by the patient. And many clinicians are feeling a sense of loss, of disconnection with their patients, a sense that they are no longer able to care well. Some of them are having symptoms of lack of compassion and burnout. In the United States, that affects about 40% of the consultations. It's in this context that sometimes we give patients tools to review ahead of the consultation, tools that, as you can see in this cartoon, interfere with our ability to make a connection with the patient and make a decision, a conversation together. For care to take place, we need to be able as clinicians to notice that there is a problem, and we must respond effectively. We must show up with the intention to care, and we must do it by fostering a relationship. Why? Because sometimes, even when using the best available evidence and using shared decision-making, our plan is not going to work well. Patients may experience unintended or adverse consequences. And we go back to that relationship to be able to care again and respond again. Without that relationship, the patient loses trust. They may go doctor shopping, may go to other clinicians, and may not end up with a solution that responds well to the problem we noticed in the first case. So in order to care, we must notice a problem, respond effectively, show up with the intention to care, and foster a relationship of trust that allows us to then recover if the care plan is not effective. So to finish, shared decision-making is an intervention that we use to figure out how to care for patients. Therefore, there is not just one kind of shared decision-making, but there are four. There is a kind of shared decision-making which we choose from different alternatives. So in this case, patient Rachel is thinking about a contraceptive intervention, maybe to use the pill, maybe to use an intrauterine device, maybe to use something else. We use shared decision-making to figure out what is it that patients want when there is conflict. So I think in Brazil, there's still a big problem with patients giving birth through C-section, perhaps at rates that are very, very high. Perhaps a patient would like to try a vaginal delivery, but their gynecology obstetrician physician finds this inconvenient, particularly on the weekends. And so we have a conflict. And so we might use shared decision-making to resolve that conflict about how to deliver. So now Rachel has delivered, but under difficult circumstances, maybe developed HELP syndrome, is in the intensive care unit. The baby is out, but the family now needs to take care of the baby while Rachel is in the intensive care unit. And so now we need to figure out, how do we solve this problem? Problem solving is a third kind of shared decision-making, perhaps the most common kind in chronic disease care. And the fourth kind is, in this case, it's clear Rachel is not going to survive. And now we need to figure out, what is it that matters in this case? What matters to Rachel, and how might we help Rachel write the last page of her life's book in ways that reflect our humanity, our values, and our goals. Four different kinds of shared decision-making that need a different approach in each case to support the patient's decision-making. One focus on alternatives and options, another on desires and conflict, another on problematic situations, and another on our humanity, requiring on the right the weighing of pros and cons, or the negotiation and reconciliation of alternative positions, or problem-solving conversations like we've been discussing during this seminar, or a dialogue to figure out what matters. At the end, we need unhurried conversations, not slow, not long, just unhurried, ones in which we can demonstrate and see clearly the patient's situation in high definition, in their biology and their biography, in a way that the plan that we come up with is a plan that makes sense intellectually, emotionally, and practically. And that's what we mean by care. So to summarize, the goal of shared decision making is not to get people to do what you or the guidelines think is right for them. Shared decision making is a method to care. We need to find ways of care that make sense to this patient, not to patients like this. And the best method to accomplish depends on the purpose, on the problem that the patient is facing at the moment. And there are tools that can help, but their use does not equal shared decision making. We need to have a conversation that notices the problem and responds to the problem well. At the end of the day, shared decision making is a human expression of kind and careful care. Thank you very much for your attention, and I welcome any questions that you may have.
Thank you so much, Victor Montori. You addressed several topics on shared decision-making field. I have some comments and questions for you, and then I will open for the audience to hear from their questions. A first comment I would like to point is related to low schooling people. We have there is a common sense that low schooling patient cannot be available for shared decision making. We are trying to develop decision aids addressing these kind of people and this kind of encounter. And I would like to hear from you which could be the best way to measure out which outcomes and how to measure these outcomes, consider low schooling people and their participation in the healthcare plan. The other point I would like to discuss is the statement that you bring to us as shared decision making is a method to care. And as a method to care, could we consider shared decision making as an innovation technology? And why do you consider it? So, and the third and last question I would like to discuss about the cost. There are some, I started to work with shared decision making since 2007 or 2006. And from that time to now, I think that things changed very lower than I expected. But nowadays it is increased. And the reason why it is increased is about that shared decision making can be an alternative to decrease health costs, which is a concern to me. And I would like to hear from you about this point of view that shared decision making can be an alternative to decrease costs. So these are the 3 points I would like to hear from you. Oh, you're mute.
No, these are difficult questions, and I'm going to try to respond quickly so we have room for others. I'll start with the last one. Every time we use a method for care to achieve the goals of the system rather than the goals of the patient, we corrupt the method. So shared decision making is a method of care. If you use shared decision making to lower costs and you have an expensive option and a cheap option, and you tell the patient, we're going to choose between this and this, but in the back of your mind, it's the cheap option that the patient should choose, then you're not being sincere when you offer the expensive one. You really don't want them to use the expensive one. And so as a result, you find yourself saying things like, well, we can use the expensive one, But who would choose that one? You should choose the cheap one. And so it's no longer shared decision making. You're selling now. You're in a sales situation. So every time other goals of like the goals of the system are being used, it's much better to use methods that are more sincere. So either the expensive treatment is not available in the system, that would be one approach. And then the decision to do that is a policymaker's decision, and they hold the responsibility for that. You do not ask your doctors to do the rationing at the bedside, you do the rationing at the policy level, and that would be more sincere. Um, or you basically decide that the cheap option is the default, and you, even if you prescribe the expensive, the system would simply not reimburse, not pay for the expensive one, and the patient needs to know that. So I wouldn't use shared decision making to hide the fact that your policymakers could not tell the public that they were not willing to pay for the expensive option. It's better to do it sincerely. Otherwise, it corrupts the method. The second thing is this an innovation technology? Uh, if you need that designation to achieve any of your goals for research or whatever, yes, you can call it an innovation in the sense that it's a new thing for patients and doctors to have a conversation. And, or maybe the tool is the technology that you're using to promote and support the conversation. I think that's legitimate. And then the first question, which is the hardest one. If you have a society that has social justice problems, for instance, a large proportion of the population is poorly educated, is not very numerate, has difficulty understanding biology, understanding science, understanding their own body, um, you have a bigger problem, and you cannot really fix that through shared decision making. So it's going to be hard to use shared decision making in which the fundamental thing you offer patients is information. It may be that you go to a mode of shared decision making in which you as a clinician do the heavy lifting, do the hard work of figuring out what is the situation that demands action and what are the values and pertinent experiences that the patient may have. And so the patient then becomes is an expert already on those experiences and those values. And then the work is to try to find the language to communicate that to each other. And you as an expert in the biology of things, do your best to try to find what the match is. Trying to give the patient information when the patient has no framework to understand that information may even be cruel. And so you might feel good that you tried to engage the patient in shared decision making and gave all this information, and you might check the box and say, I gave information. But if that information was beyond the ability of the patient to process it, then you might just have been cruel to that particular patient who now feels worse for not being able to participate. What I've seen, for instance, in Peru, when we've talked about this, is that clinicians see the patient, see a patient of humble origin, perhaps judged by their dress or the color of their skin, makes an assumption about the patient's ability to participate, decides the patient cannot, and then tells them what to do. And that is not just cruel, but it just furthers the unfairness of society and makes the physician an agent of injustice. And that is not care.
Thank you. We have some questions from the audience. Um, there are many. Miriam Silva is asking, thank you so much, Dr. Montori, for the lecture. Is there any simulation of shared decision-making that we, as health professionals, could watch? You are mute.
This is a tragedy every single time I stay mute. So particularly someone who really likes the sound of their own voice, they shouldn't be muted, right? So the I just demonstrated to you, for instance, that statin decision aid. I think that's the simplest tool. And the way I would do this, if you want to simulate this, and there are videos online, if you search for the care unit on YouTube, there are several videos that we put up there where we demonstrate some of these tools. But the best way is, for instance, to pick up the statin decision aid from the website and use it on one of your colleagues and have the discussion with one of your colleagues. It's not very difficult to do. It takes only a few minutes. And you will recognize aspects of your own language when you do it with one of your colleagues, where, for instance, you may use too much jargon. You may use terminology that is not easy to understand. And as you practice with each other, you might get to the point where it's actually fairly easy to just make the case that Mirhelen was making early on. When we tested the statin choice decision aid in a very busy clinic in China, we had several problems related to that particular tool that is so simple. The first problem was the context of the clinic. The way they, I don't think that you do this in Brazil, but the way they do it in China is the clinician is sitting at the desk, and then standing on the other side of the desk is the patient they're seeing, standing. They don't have time for the patient to sit down. The patient is standing in front of the desk. Behind that patient is the next patient. And behind that patient is the next one. So the line starts at the desk of the clinician and leaves the office and goes out into the corridor and goes around the building. But it starts at the desk of the clinician. And so the line, the queue, the people behind are also participating in the encounter. So when one of our colleagues in China pull out the decision aid and start describing it with this patient, the next patient start asking questions about the shared decision-making tool that they were using with the patient that was ahead. And there was a big confusion that started. And my colleague, I mean, this is all in Chinese, I have no idea what they're saying. And my colleague recognized the confusion and goes under the desk and pulls out a model of the heart, a physical model of the heart, and then points at the heart and then points at the chest of the patient. Now, what's striking about this is this particular clinic was of patients that were being discharged from the hospital after a cardiac event. So they had been 2 or 3 days in the hospital with a heart attack or unstable angina, one of these things, and they had no idea what the heart was, where the heart was in their body, or why in the world they would try to take a cholesterol medicine to prevent heart attacks. So it's very, very hard to know what you're going to be dealing with and how best to do, but it became very clear that a tool as simple as a statin choice was not well designed to deal with both the clinical format and the knowledge base of the average Chinese patient in northern China.
Thank you so much. There is another question from Marta Machado. First, she says, congratulations, care should be the basic of our medical approach. In these days, care is becoming more and more forgot. How to improve it to our medical students? Nice question.
Yeah, great. I share your concern. I share your concern that care is becoming less and less what we do in healthcare. I have written a book called Why We Revolt that Mirhelen nicely mentioned before. It's available in English and Spanish. I really wish there was a version in Portuguese.
We should it.
Yeah, and but that book is all about the fact that we are that the healthcare system is forgetting to care and failing to care, and that we need to fight back. We need to have care in healthcare, and instead of processing patients through, which is oftentimes what we do in busy clinical environments. So the best way to demonstrate this to medical students is first to acknowledge that we have a problem. If we pretend that we don't have a problem, they won't see it. They just assume that that's how it's always been. You see, they've never seen anything better. So you need to demonstrate, to tell them that there's a problem. And then you as a teacher, as a role model in front of them, You have to try your best to demonstrate what care is about. Every time we use a tough language, a hard language with patients, every time we joke about patients being our enemies, overwhelming our emergency room, or overwhelming our waiting area, or just too many and becoming overwhelmed, where the system is creating that, but we blame the patients for coming to see us. Every time we do those things, we kill a little bit of that soul of the medical student who joined medicine, hopefully, to care for people. And the worst way of killing the soul of a healer is by making them cynical about medicine, about care. So in order for people to remain compassionate and committed to excellence in care, they need role models who are able to care despite the system, rather than role models who become burnt out and cynical about the system. So don't be a cynical role model. Be careful about the jokes that you use. Be careful about your comments that belittle patients, that disparage patients. Aim your comments at the system and make every student and every colleague an activist for a healthcare system that is about care, that is careful and kind to patients. Patients are already suffering. To, on top of their suffering, have to suffer the system in which you work, or suffer a callous, cynical, and tired clinician who has no business in front of another human being suffering. So role modeling is absolutely the #1 way in which I would do this with medical students. No more lectures about it. When they go to clinic, they should see clinicians who deeply care and fight for a system that's more fair and more caring for their patients.
Thank you so much. There is another one. According to, it's from Ian Silva, according to a developing country as ours, do you think that shared decision-making could be expanded, if feasible, into a family health strategy for primary care health?
I think primary care and family medicine are particularly suited for shared decision making, because it's in the relationship, in the continuity of care that you expect from primary care, where some aspects of making decisions are already figured out. As you know each other, you start getting good at making decisions. And I would start with simple decisions, like the preventive decisions. You know, should you get a mammogram? Should you start a statin? Maybe decisions about lifestyle, you know, about going for walks or exercising or whatnot. Because eventually you're going to find yourself as a primary care clinician making decisions about cancer treatment or end of life care, or like in the case of Merhelen, when she's looking at her patients with inflammatory disease, and they have to think about a biological with a risk of infections and cancer versus other medicines that have other adverse effects. And these are serious, difficult decisions. If that is the first time that the patient encounters the opportunity to make decisions together, that's going to be really hard. But if they had previous opportunities to gain confidence in participating, in knowing that you are actually inviting them seriously to make decisions with you, if you already have exercised that opportunity, if you've practiced that, the next time when it's really, really serious, then it would just be another, this is how we make decisions together. It becomes routine. And that's what, you don't want shared decision making to be this special thing that we do sometimes. It's just the way we care. It's a method of care that we use routinely. And to be able to do that over time, you need continuity of care. So arguably, it's something that is better seen as a core skill of primary care and family doctors in continuity of care. Of course, specialists are going to have to make those serious decisions as well. So they have to really get good at it without the advantage of being experts on the patient, with the major limitation of only being experts about their disease. I say that as a specialist. And so I think it's particularly important to advance patient-centered care and shared decision-making as a method of patient-centered care in primary care.
Thank you so much. We could stay here asking and discussing more and more It's a very fascinating theme. Uh, Lapa, would like to say something? Yeah, you are mute.
No.
Oh, okay. Lapa,
Okay. Thank you so much, Dr.
I'm not hearing you. You are mute.
Mute. Can you hear now?
No, continue mute. You can unmute.
Okay. You know, possible? Is he hearing me?
We can hear
And
you,
now,
but very low volume. It looks like your microphone is far away from you.
Okay.
oh yeah,
What about now?
now
Can you
now
hear?
it's better.
Excellent. So first of all, I'd like to apologize for being late. I was exactly teaching our medical students. And one of the things I always tell them, you have to empower your patient to make the decisions together with you. But you know, our audience here is mostly of uh, graduate students, masters and doctorate students. And one of the things I'd like to really show to them that even with this thing that we learn as we come to medical school from the very first day, right? But to demonstrate this, we need evidence. And you said exactly that. You said that you still need evidence to demonstrate that this method or shared decision is better than any other method. So that's the thing I would like to demonstrate to them who are preparing the thesis, that we need to find the evidence to demonstrate our goals. Thank you so much. Very inspiring talk.
Thank you very much for those words. There's a ton of room for research, and I know we have another session next week where we're going to perhaps go more in depth on those areas. But as you think through between now and then, think about what are the opportunities that are particular to the population that you're trying to impact. So, and think about the population for shared decision making as including both the patients and the clinicians. It's not just the patients, right? This is a conversation between the two. So patients and clinicians are both the participants in your research or the subjects of your research. Also think about what might we do to better prepare patients and clinicians to work together. And so there are efforts in other places, for instance, to have patients come together, patients who have similar situations come together and discuss as a group what they might want to do. So we have done some experiments with women when they turn 40. In the United States, there are some places when they turn 40, they get invited to get mammogram screening for breast cancer. And so usually it's a notice, come in and get your mammogram. And there's no consideration of whether that's actually something that the woman would like to do. So we now have a program where we invite women who just turned 40 to come together. We serve tea and cookies or something, and there's a social thing. And there is a family doctor in the room, one, and there's 10, 12 women in the room. And we give them material about the pros and cons of screening. And then they have a discussion among themselves about what the reasons they might have to go for screening and the reasons they might have not to go for screening. And in listening to each other, they form their own values. They form their own opinion about what they would like to do as a strategy to deal with the risk or the threat of potential breast cancer. And the physician is there in the room to answer any questions. And usually they don't have to answer many questions because the information is right there. And what you see is these women trying to understand what are the issues, trying to understand what are their values, and dealing with the uncertainty about what is best for them together. And so it's automatically culturally appropriate, is automatically the discussions or at the cultural level that they can handle, and the clinician is there to correct any misconceptions that may appear, not to tell them what to do or what they should choose to do. So then when they go to their clinicians and they decide if they're going to participate, they're ready to have that discussion because they've had an opportunity to discuss with their peers how to handle. That is potentially a very scalable approach to shared decision making for a few decisions in which you would like to prepare people ahead of time, and you rely on community health workers or you rely on peer groups to do that. That kind of creativity that is appropriate for the context in which you're going to be operating is something that nowhere else in the world can happen but there. And so you have a great opportunity to explore this in depth if you are interested in this topic.
Thank you so much. We will continue with this.
The crisis.
Sorry?
If I said we are in a prime position to do that if we can survive the crisis.
Yeah, yes, yes, sure. So next week we will continue with this theme on shared decision making, and we will have a roundtable about decision aids, uncertainty with Victor Montori and Ian Hargraves, and they will talk more with us about this very fascinating theme on shared decision making. Thank you so much, Victor Montori, and see you next week. Bye.